I think the people that have lived here a long time, we take for granted a lot of things. We don't even think about how beautiful it is and the lakes and water and all that. Yeah.
Yeah, I was talking to Liz about the view from her office, and I said I would never get anything done.
It's like we have Paul here.
And
Oh, good.
she said, "Oh, you get used to it," and I'm like, "Yeah, I guess you do." But yeah, I live north of Dallas, and when I moved there with my parents, it was all cotton fields.
Oh, wow.
Now it's like wall to wall building, I mean, suburbs and buildings and all of that. And it grew over the years that you're not really even aware of it.
Yeah, that's the.
Can those online see our screen? No. Why is it telling me Alberta's on too?
Can you go into your Teams and share?
Okay. No. Looks like she made a different.
I'm on my phone for right now.
Okay, can you see the screen?
No. Not on my phone, I can't.
Okay.
No, I take that back. Yes, I can.
Okay, good. There was something that happened with the computers in here and they're messed up, so I'm glad you can see that. We'll just wait just a couple more minutes or maybe another minute. We have another provider we're waiting for, and then we'll start. Okay, 7:15, so I will start and we can catch them up. Hello, you can sign in and are you here for the provider one?
Yeah.
Okay, so you can sign in and grab a packet.
Okay.
If your name's not on the list, you can add it to the bottom.
Okay, thank you.
So I'm Rachel Turner. I'm from here at OMC in quality and we have, sorry, you just took a drink.
I'm Bridget Byrne. I'm one of the Chartist consultants. By background, I'm a nurse practitioner, and a neurogerontologist.
Do you want to introduce yourself? Sorry about that.
Yes, so I'm David Bain, one of the GIs here. Been here for 3 years.
Okay. And online, would you like to introduce yourself?
Joe Polero, one of the hospitalists. Can you hear me?
Alberta Stamp.
Yes. So we have Alberta Stamp from PI, and we have Dr. Craven from the emergency room.
I'm Julianne. I'm also from the emergency room.
Okay. So we are here to talk to you today about our CMS regulatory training. Why are we here? Do you want to talk about Chartis?
We're here, Chartis is partnering with ONC. We are a consulting company that works on compliance and regulatory and sustainability. And we're here as a result of the active CMS regulatory response that has taken place over the last 4 surveys.
There is a QR code. It's both in the handout and it is floating around here. So you can scan this if you have any questions that you come up with, or even later you come up with any questions, go ahead and add those in. Here's our, why are we here today? So she talked about, we have 4 surveys. This one does only show 3, but there is a 4th one in there. So we had one in February, one in April, one in June, and one again in August. The one in February was our immediate jeopardy, where there was some scramble. We had to correct some things within 24 hours to stay open. We did that. We're still trying to get out of the DOH's, we're trying to get the DOH off of our back, I guess is the best way to put it. There is certain levels, so the conditional levels are the ones that we're trying to clear and get out, clear up so we can get past that, and then they'll come back at a regular interval and not every 6 weeks or so. So we received our CMS report A19. We sent our plan of correction in. We have not heard back from them to approve it or not, but we're going to go live with what our plan was to DOH. And so we're doing the training this week, and we're going to start that next week. And what that's going to look like is we're going to have people boots on the ground, both Chartis staff and OMC staff, going around doing real-time audits of charts. So we're going to try to get corrections real time. We're not asking anybody to lie and make anything up on the chart, but if something was just missed and not documented, that's what we're going to be doing. We expect that DOH will be back within the next couple weeks. We do not have a date. They do not give us. It's just they show up when they do, but they have a deadline of 10/10 that they have to get their report back to CMS. So that's why we're expecting it within the next 2 weeks. So some of the topics we're going to cover, and some of these are just around nursing, but we want to make sure that you're aware of what's going on. So there's pediatric behavioral health and substance use disorder response, neonatal glucose management algorithms, documentation and monitoring of assessments and reassessments, titration of medications, patient dispositions, massive MTPs, restraint and seclusions, and then our next steps. So the pediatric immunization status is a Washington state only requirement, and this is just to make sure that you're aware that in the ED, all pediatric patients that come through have to be screened for their immunization status. Doesn't mean we have to do anything else with it, that the staff nursing triage must assess for, or ask them if they have their immunizations up to date or not. Again, that's Washington state only. The SBAR, so this is something that we're talking to the nurses about, is communication tools. So this may be something that you might be seeing more of. Again, it's not, it's just a tool for communication that they may be using. Sorry about this, the computer, I think it's the internet, is being a little slow. There we go, pediatric behavioral health and substance use disorder. So we were cited for not having a policy or procedure for dealing with pediatric patients. So we've had one for adults. We've been working on one for pediatrics for quite a while. It's just there's a lot of moving parts, and we've been really focused on DOH, and also Washington State is quite specific in the requirements for things. And so it's been a little bit hectic to get here, but we do have a new policy. It's similar to the behavioral health crisis policy in place for adults. Again, that's driven by state regulations. And so we have a new policy that'll be out. If it's not out already, it will be live by next Monday. So it's for, here's the policy, and you can look on SharePoint for that. And we also have behavioral health concerns reference guide. So this is, if we have a patient with this behavior, what are some interventions we can do? Again, this is just a guideline. This is to help people. Hi, if you want to sign in, yeah, thank you. Just to help people of what they could do. Again, you can do what you feel is right for the patient, just some guidelines. We have a new behavioral health workflow. So before we did have some for adults, we didn't really have much for the children, but this is for everyone. So adults, adolescents, peds across the board. And again, it's a guideline. You don't have to follow it. It's just a guideline for what could we do or what maybe the path we could go on. And then for those patients that are elopement risk, again, we put them, these are guidelines. So we have full decision capacity, what can we do if they have suspected impairment of their capacity, and then the patients who are on ITAs. Again, we want to try to get those patients into those elopement scrubs, the maroon color, but it's not a requirement. Anything to add? Neonatal algorithm, I don't think we have any pediatric doctors, but neonatal algorithm. So we were cited because our algorithm titled Newborn Glucose Screening and Hypoglycemic Management algorithm was not revised, reviewed in the time outlined by hospital policy, but it was not outdated actually. The policy was not changed, the algorithm is not changed, but is reviewed and now current. The algorithm is built into Providence's Epic, and so that will be something that's pulled up when that's ordered or nurses are looking at it, which looks like, so here's the policy, and off to the right there is that algorithm for nurses to follow. So just so you're aware that it's there. Sorry, a little bit slow on the internet today. So monitoring assessment, of course, we want to make sure everything's documented and everything we're telling the story, because people that are looking at the charts, including myself later, might not know what was actually happening in that situation. And if it's not documented, there's no proof that it happened. So that was our next big section of citations. This has to do with documentation, the neurochecks, INOs, the vital signs, PACU assessments, neonatal assessments, uterine assessments, and the MEG sulfate assessments. So again, that's heavy on the nurses, but just so you're aware. And another thing that has popped up is the orders. So sometimes the orders for these things might not make sense, or that they're not able to be followed by a nurse. So say the neurochecks, we've seen an order that's multiple times that says neurochecks with vitals. And so if that patient's in the ER or maybe ICU where they're getting frequent vital checks, that may not be feasible to do those neurochecks every 5, 10, 15 minutes for that full neurocheck. So if a nurse gets an order that's confusing or is not feasible, we're asking them to reach out to the provider for clarification. It doesn't mean that they're saying that you have to change it. They're asking clarification. Sometimes like that neuro with vital signs won't be feasible in the ED if they're, especially if they're hooked up to monitoring and they're checking those vitals every 5 minutes. So just so you're aware, the nursing may ask for clarification on some orders. So nursing, this is again, nursing documentation. They need to do those post-op vitals. Titration. Titration, we were cited because staff did not follow the provider's orders for titration, and we didn't document the RAS scores according to policy. We have revised our policy to make it easier to follow, not so strict for nursing to where there's possibility of fallout. So the new policy addresses titratable drip management in general. Before it only really addressed the RAS score. So now just what we want to add in is that there's no required frequency in which targets should be documented outside of dosing adjustments. Before it was pretty specific of what they had to document and when. And so it really left no room for them to do their work that they need to do and take care of these patients because they were so heavy on documentation. There's some added language in there for nurses to be able to titrate down without a physician order. So just so you're aware, that's in the policy. And then we have, again, that policy is going to be live either now or if not, it's going to be by Monday. So again, if you get a call to clarify the order, please provide the order for clarification. They're not doctors or APPs, they're just asking for clarification. The next section is on disposition transfer orders and EMTALA forms. It is not an EMTALA violation, just so you know, it's just the documentation that we have in there. So for the ED providers, the disposition in Epic for those ED patients, we need to make sure that you're assigning that. We have seen nurses do that, and it's okay if the nurse does it as long as you also do it, but it can't be only the nurse that does it. The provider has to assign that disposition. The IMTALA forms for any patient transferring out, we need to make sure that doctor or that provider has the signature on there. Electronic is fine. What we saw happening is that the nurses were trying to be really helpful and they were printing out that form and then trying to get a signature from the provider, and then it was getting lost and it wasn't always getting to medical records and scanned in. So just make sure you're doing that electronic signature. And then if that transfer disposition changes, so they change to a different facility, just so you're aware that you'll have to go in and re-sign that IMTALA form. And then we want to make sure that the patients sign anytime possible on those IMTALA forms. We don't want to rewriting verbal for somebody that's definitely alert and aware and just says, sign it for me. We want to try to get that patient's signature, but if there is a reason we have to write verbal or the patient can't sign, try to get a family member or write a clear document reason why we didn't get their signature on that form. And here's just some tips and tricks on that. MTP. So MTP has had a lot of work done on it here at the ONC. So the areas we got cited for was lack of a provider order to actually transfuse the blood, temperature monitoring, and no provider orders to discontinue the blood following the initiation of the MTP. So what was happening is that if you aren't using the order set or if you're accidentally unclicking boxes in the order set, it's not actually letting the nurse transfuse the blood. They were still transfusing it because that's what we want to happen, but just make sure that you have, if you're using the order set, it's all in there. You don't have to worry about clicking anything extra. Just be aware that we need that order. They actually can transfuse it. They also need to make sure that they do their vital signs. And then when the MTP is complete, just make sure that you're discontinuing that order. We had an order that just sat open for a long time. And so that the surveyors are saying that, that's not okay. You need to discontinue that order. Oh, and added, let me go back one step. The house supervisor is going to facilitate the MTP debrief. So they're going to help look at that. And the EDD charge nurse is going to, if it's in the ED, is going to be looking at that real time, making sure everything's there. But the house supervisor is going to facilitate that MTP debrief. And we did have a question that popped up this morning is what if you're right in the middle of that, case we need that MTP, I can't go to the computer and order it. It's okay to put it in afterwards. We just want to make sure we have that order. So we know that this is a critical situation and you're at the patient's bedside taking care of them. So it's okay to put the order in after retrospectively. Just make sure that order is in.
Any questions around MTP? That's generally probably the most questions of all these series. Okay, good.
So we do have the massive transfusion protocol algorithm that just kind of outlines what people should or could be doing, actually should be doing. And then the activation guideline. Massive transfusion protocol orders. All of those are available, tips and tricks if you need them. And that's a nursing reminder, that's not for you. Okay, restraints and seclusions. So this one tends to always be a citation somewhere. They find something wrong, and it's not just us, it's across the state. It's just a big patient rights area, and so we want to make sure that we try to get this right the first time if we can. So there's nonviolent and violent restraints. Nonviolent are the ones that we're putting on usually for an intubated patient that's trying to pull out their tubes. Once in a while, we'll use it for maybe a dementia patient that's just trying to pull out their IV or something other. So those are the ones that are, we put the order in, nurses watch them, nurses take them off as early as possible, and then you're good. All you need is the order. Violent, self-destructive, which includes the physical holds, the physically escorting them, not letting them leave. Physically, maybe we have the 4-point locking. We hold them down for medication, or seclusion. Seclusion is also a violent restraint. And so those are the ones that we want to make sure that we are, we have to document clearly, and we have to document everything per CMS regulations, and we also have to remove them at the earliest possible chance. Additional types of forensic restraints. So this has been a question that's came up recently in the ER is what do we do when a patient comes in handcuffs with police custody? That is not for us to worry about. The police, that's outside of OMC's, that's outside of our facility, outside of our scope. They're in the police custody in handcuffs. They deal with that. You don't have to put an order in. We don't have to do documentation. But if we remove them from handcuffs and then now we have to do some kind of hold, that's when we'll have to go to our process. And the seclusion is involuntary confining a patient alone to a room area where the patient is physically prevented from leaving. So usually what we see here is a locked door. If they are just in the ER with the door shut because they want privacy or they need to calm down and they're okay with you shutting the door and it's not seclusion or not being locked, they know they can get out, that is not seclusion. Chemical restraints, we don't do these. They're prohibited by CMS. And a chemical restraint is a medication that is not part of the patient's standard medical or psychiatric treatment and are administered outside of the standard dosage for the patient's condition. We have had some questions from staff saying, well, we do chemical restraints, but a chemical restraint is the off-label use of a medication to manage a violent behavior, use of anti-anxiety or sedating medications in doses not intended for the symptoms, so higher doses, or we're trying to just put them down. If we're giving them a medication that's in a standard dose and we're trying to treat and manage their behavior or get them to be able to participate in their care, that is not a chemical restraint. What we want to make sure is that we're clearly documenting if we've had to give them a large amounts or maybe say what I've seen documented as a B52, documenting the reason. And I have actually seen where we've had providers write, I chemically restrained them. I gave them a B52, those sort of things. And we want to make sure we're not documenting that, or we want to make sure that we're documenting the reason we gave them that medication to allow them to manage their behavior, to participate in care, those sort of things. Because if we get into doing chemical restraints, which we don't want to do, is then you're going to have to start doing those orders for violent restraints every time you give them the medication. We're going to have to do face-to-faces. We're going to have to do everything we do for violent restraints, you're going to have to do for these cases if we get into that whole realm. And then we're going to have even more scrutiny from CMS and DOH.
So treating to improve the underlying condition that's exhibiting behavior.
So-
And documenting that.
Right,
Yeah.
so I get the Ativan 2 milligrams for whatever the behavior or the symptoms you're seeing are. Not to say Ativan as a chemical restraint.
Yeah, and not PRN.
Nope.
Not PRN medication, yeah.
So again, this is just some clarification on that. We've always given to enable them to participate in their plan of care, not disable them. We're giving them the standard treatment, standard dosing, not disabling them. And again, hopefully everyone's aware, but we need that face-to-face for any time that it's a violent restraint or seclusion. That's including the holding the patient. We need that face-to-face after the start of the episode, but it must be within 1 hour of the start of the episode, and using the OMC smart phrase, and that clearly you're documenting, all of those points. There's 4 free text lines. Please fill those out. Actually, there's 5. And please document the behaviors, just so we have the clear story. As we were talking about earlier, it's documentation. And if we don't know the story, we're just saying that the patient was put in restraints, people will question that, including the DOH.
This is a hot topic across the nation with CMS, and I have worked in a facility where that patient was restrained for almost a year. They were in restraints and seclusions, in and out. And so if it's really longer than 24 hours, you're going to get deep scrutiny on that. But it is huge across the nation.
So it makes us all appreciate the work that's going on in the ED with the back and forth, face to face and in and out and relaxing at the earliest opportunity. As soon as they fall asleep, taking the restraints off. If they act out again, treating to help them. Yeah, just a lot of appreciation for the work in the ED around this thing. It's very complex, but they're doing a good job.
Yeah, so that brings up the point is at earliest possible time. And of course, this is mostly on nursing, but if you're seeing something, you can get them out earlier too. You can have the nurses discontinue them. But we want to get them out as, if we see the patient sleeping and they've been sleeping for 15, 30 minutes, we can discontinue that seclusion. Or if they're calm and they're cooperating, start removing those restraints. If we have a nonviolent patient who's in restraints, intubated, their RAF scores are getting low. They're looking at like -3, -4, -5. They want them out of those restraints unless we're actually documenting that they're pulling at the tubes. But at those levels, they shouldn't be pulling at the tubes. A couple other things for providers is medical staff training on restraints and seclusion policy upon hire. So the wording has been updated on that they have to have that within 90 days of hire or before placing any orders. So especially for hospitalists or any ED providers, we have to have you have to do your training and attest that you read the policy before you can order any restraints.
If I could mention, everybody this week has just been assigned a read and a test you've read, the restraint and seclusion policy that's been updated. This is it. There's a copy there if you want it. It's 3 pages. It pertains to this stuff. Basically, open up your health stream, read it quickly, the parts that are interesting and pertain to you, and just take the test, which is do you a test or not, and boom, you're done. But we're doing all of that before Sunday. This is part of the Chartist guidance to us to get these things accomplished and prove to CMS that that everybody that might be touched by these areas has done it, and we just keep moving forward with the work at edible training. So thank you everybody for that.
The other thing I want to inject is if you have a patient who's in restraints, especially this pertains to the ED, and you know they're coming up quick afterwards, and you don't feel comfortable releasing it, it's just documenting the behavior. You know, yes, they may be sleeping, but based on experience, they've come up quickly and fighting. So they just want to know why, making sure we're telling the story. Or you can say for staff safety, that is a significant rationale for keeping someone.
And so with that, we have updated language in the policy that says that the episode should only continue if the documentation of the observed behaviors demonstrates a threat to the immediate safety of the patient, staff, or others. So if documentation does not demonstrate a threat, we must discontinue. So that's where discontinue as early as possible instance. For nonviolent restraints, we would like those nonviolent restraint orders to be in before the initiation of restraints, because usually those aren't an immediate violent episode. We're just trying to keep them from pulling tubes. So that one we ask that they're in before restraints, but if not, that's okay if it's as long as it's a few minutes after. Violent, we understand that it needs to be a few minutes after, but we want it as soon as possible after, because if they're putting in an order an hour or two later, they're going to question why did it take an hour or two to get that order in for that restraints. Of course, we talked about the face-to-face evaluation has to be in. We use OMC Smart Phrase. Please get that in with it. It needs to be done. The face-to-face has to be done after we started, but within 1 hour of the start. You can put it in later, that's okay, but you have to actually do the face-to-face within that time frame. For seclusion and violent restraint, those 15-minute checks that say a trained observer does, we've changed it to where they don't have so many elements. They just need to do the observed behavior, just so you're aware that you may only see that in the charts. The education we talked about is that providers have to do it within 90 days of their privileges granted annually and before they can place an order. So the house supervisor is supposed to, as of right now, respond to any violent restraint or seclusion episodes, because they're going to help make sure that all the documentation is in place and everything was done properly and that they're removed when there should be. So if you're not seeing that, we can always call in a house supervisor to come do that. Next steps. So care facilitator process, that's going to happen over the next several weeks. We have both Chartist is going to be on site over the next couple of weeks, and OMC staff is being trained. So what we're going to do is that real-time audits of charts. We're going to be here all shifts. We're not going to be here 24/7, but we're going to be here all shifts. And we're going to be looking concurrently at those chart documentation for that shift. And if there's anything that can be corrected that was actually performed, we are going to ask that that's corrected. We're not asking anybody to falsify records. We don't want anything documented that didn't happen. But if something was missing or something needs to be elaborated on, we're going to ask that that happen. So we may ask that something be added to documentation, or maybe a face-to-face, or that sort of thing. But again, we only want what actually happened to be documented, and just be aware that that may be happening. It's probably going to be mostly with nursing, but we may ask a provider too. Any questions? Any questions on the line?
Anything from your level, Dr. Craven?
I guess the question I had for the MTP protocol, just to confirm, like we can verbally activate that and go back and order the set later, because I'm definitely concerned for the, ramp rescue that gets dropped off and I'm actively doing a resuscitation. I don't want to have to step in the room to put in a physical order into Epic.
Correct. Just like any other, emergent code situation, you can definitely do verbal. We just want to make sure that you afterwards go in and put that order and make sure the order is in, that they can actually infuse the blood.
Cool. Sounds good.
If you're using the order set, it's built in there. Just, I don't know if people just weren't using the order set or they were unclicking that box. And so we had the order for the blood, but we didn't have the order to actually transfuse it to the patient.
And one thing in the revised MTP that's in front of the med exec right now, I'm sure it will be approved by next week. We've got support on it. One of our indications for starting it was if you've reached 3 units in an hour, but we've changed that to that, and or if you feel it's likely you will need 3 units in an hour, so you can anticipate the need earlier and fire away, so you don't go through that kind of stall phase where you're waiting for blood the usual way.
Anything else that I missed that you'd like to cover, Dr. Kennedy?
No, just a reminder that a big part of this is that nursing is going through a huge list of things where they are being reminded you need to have an order, and if it's unclear, you need to clarify the order. So there will be more calls for a while about clarification if the orders are not clear, because nurses are being very careful to stay within the scope of their license. So please, lots of grace for the work that nursing is doing to feeling a little paranoid, actually, I think, that am I in, am I out? So help with clarification where needed. And the more you can write orders that are clear and are not excessive if they don't need to be, like with vital signs, we don't want Q15 minutes kind of forever. Nobody does that, but you know what I mean. The more doable it is, the better the situation is. And I think we need to keep looking at all of the kind of orders that we're used to giving for doability. And so work over time, but thanks for your effort on it.
And if any questions come up, you can still use that QR code. You can send it to quality, Dr. Kennedy, anyone, and we'll get back to you with an answer.
Good, thank you, everyone. Yeah, really appreciate your time.
We don't need to pick up the paper copy, just read it on the.
Just read it on
Yeah.
Hillstream and
Okay.
boom, we're done. Yeah, it's really quick. Thank you so much.
Thank you.
Okay.